Hello, I'm Raajit Rampal from Memorial Sloan Kettering Cancer Center in New York. I'll be moderating this session on MPN subtypes. The purpose of this session is to discuss and to debate whether we think that MPNs are in fact discrete subtypes or whether they may in fact just represent a spectrum of diseases. Our first speaker will be Dr. Jerry Spivak from the Johns Hopkins School of Medicine, Baltimore, who will make the argument that MPNs are a discrete subtype.
I want to thank the meeting organizers for the opportunity to take part in this important workshop. My assignment is to discuss the myeloproliferative neoplasms as discrete subtypes. Now, where I want to start is the WHO classification of the myeloid neoplasms in acute leukemia. And I'm going to assert that these three illnesses do not belong in this classification because they all share the same set of driver mutations. Now, this slide proposes some conundrums. How can one mutation cause three different diseases? Or how can three mutations cause the same disease? And the answer is very simple. It has to do with host genetic variation, which will explain the genotype-phenotype behavior of the MPN. First, there's population attributable risk, then there's familial predilection, and then there's age and sex. And I want to go through all four of these. First, population attributable risk. It turns out that on gene-wide association studies, there are signal nucleotide polymorphisms and haplotypes of these SNPs which associate and cis with the JAK2 gene and JAK2 V617F expression in the population. And I've shown you two important haplotypes here, this with 20, both with 20 SNPs, only one different between the two. And these haplotypes provide a germline predilection to having the JAK2 V617F mutations. I want to emphasize that patients with CALR and MPL may associate to a lesser extent with these haplotypes. And there are other haplotypes which cause patients to have a predilection to express any of the NPM driver mutations. Now, the importance of this is that because of this population attributable germline risk, MPN driver mutations are not mutually exclusive, but they will differ in their allele burdens, which is a very important concept. And this slide shows patients with PV, ET, and PMF who overlap JAK2 with CALR type 1, 2, or other, or with MPL. And allele burden is what distinguishes patients who have more than one NPN driver mutation. So we'll stick with JAK2 V617F since it's the most common mutation, and it is on the short arm, the P arm of chromosome 9, and each of us has two alleles. And when one allele mutates, we will have a cell with a heterozygous mutation. When there is uniparental disomy or crossing over or duplication of the gene with the JAK2 mutation, the chromosome with the JAK2 mutation, you get homozygosity. These cells will out-proliferate either normal or heterozygous mutated stem cells. And you will always have an allele burden greater than 50%. Here, the allele burden is less than 50%, and actually these cells don't compete that well against the normal alleles. Now, here's a patient, a 39-year-old man who was referred for evaluation of thrombocytosis. He was asymptomatic. Over 9 years, his platelet count had essentially almost doubled. He had the standard workup. He had increased megakaryocytes with bulbous nuclei. Therefore, he couldn't have CML. Everything was normal except his platelet count. He had a low erythropoietin level, which is compatible with either ET or PV. And a BCR-ABL assay was positive with a mutation burden of 6.4%. CML usually presents with 85 or 95% of the cells containing the BCR-ABL mutation. He had a JAK2 qualitative assay, which was positive. His physicians were puzzled. They sent him to me. We did a quantitative allele burden, which you can get commercially, and indicated that the patient's thrombocytosis was due to the JAK2 mutation and not the BCR-ABL mutation. Now, what you see in the literature and on the forms that come with your JAK2 V617F results is that measurement of the MPN driver mutation allele burden is not informative of diagnosis. This is simply untrue. This is a lovely gene-wide association study in our population study in Denmark. These are the allele burdens at the initial part of the study, and you can see there are patients here or individuals here who have no disease but have sometimes substantial amounts of the mutation, and there are other patients who have the mutation though they have low allele burdens. Examined 4 to 9 years later, you can see there are still patients who are JAK2 V617F positive but don't get above a low percentage, whereas most of the other patients had shifted over. So you can have a low level of JAK2 V617F and not have disease. Therefore, quantitation is essential. Now let's move on to familial JAK2 V617F, and you can see here's a pedigree. Here's the proband here, and this is going over 3 generations with ET, PV, and PMF. At the same time, here's another family with hereditary JAK2 V617F mutations, or I should say familial, but it skipped a generation. But you will note that in these 2 generations, one patient was positive for the GC haplotype, encoding predilection for JAK2 V617F, and another was positive for a second haplotype. So the haplotypes are not familial predicated, but the disease can be. Finally, there's age. And when I used to look at this particular slide of population frequency over time, I always wondered why there was a distribution over this wide an age range. And you'll note in the slide that I've put acute leukemia here because over age 60, these curves tend to coincide. And over here I have the chip analysis with a low level of a mutation, which goes up as you get over 60, and the rate of leukemia goes up at the same time. Well, what is going on here is the fact that there are a group of mutations that are age independent, JAK2 being one of them, and it tends to go up with age, but you can get it at any age. And you can get a myeloproliferative disorder at any age. So here is age and JAK2 allele burdens, and this is age on this axis, and then very low allele burdens that I would attribute to population attributable risk, and very high allele burdens, which I would attribute it to age, the homozygosity here. And you can see that there's low levels more as you get older of JAK2 V617F expression, and then you get the uniparental disomy and the homozygosity with time. So this puts all this together with sex, females here and males here, and what you can see is females get MPNs at an earlier age than males. They get more ET and PV. Males don't really catch up with ET, but they do with PV. But you'll note that myelofibrosis occurs early in men and later in women. And acute leukemia is essentially a male disease until you get very old. And also there's a nice biphasic variation of ET in women. So there are sex differences. And if we look at this old slide from our lab on allele burdens for neutrophils and platelets for ET and PV, the allele burdens are always higher in PV, whether for neutrophils or platelets, than ET. But you'll note here 3 women who have no JAK2 V617F in their neutrophils, but they certainly have it in their platelets. So this takes care of some of the triple negative patients. And just to quickly point out that these diseases, PV and ET, are much more benign in women than in men. So let's look at what's going on here genetically. Here's your stem cell. Classically, this was the pathway that everyone thought occurred, but actually stem cells can make megakaryocytic stem cells, so you only get JAK2 V617F in your platelets, or you can get it in megakaryocyte erythroid progenitor cells or in all three cell lines. So PVERA is the ultimate consequence of this mutation. In this phase, things are myeloaccumulated, stem cells expand very slowly. Interferon acts here. Here's the myeloproliferative stage, is where ruxolitinib acts, and here we can explain things on JAK2 V617F. And of course, there's anticipation of the myeloproliferative neoplasm. So essential thrombocytosis is really only a syndrome. Many of the female patients develop polycythemia vera. Many of the male patients go on to primary myelofibrosis. These two go back and forth. And again, polycythemia vera is at the apex. And this is clonal evolution or succession. Here, this is a male with ET with a normal hemoglobin level and a relatively low level of JAK2 V617F. And as his allele burden shifted to homozygosity, his hemoglobin came up and he had polycythemia vera. This is clonal evolution. Here's clonal succession, where a woman with 17 years of primary myelofibrosis evolved to polycythemia vera in spite of hydroxyurea. So then one may ask, are the myeloproliferative neoplasms three separate diseases, or are the same manifestations, different manifestations of the same disease? Well, here are the explanations for these translations: either clonal succession from the stem cell, clonal expansion from uniparental disomy, or plasma volume expansion masking the increase. And this is in red cell mass. This is probably the most common. Now we get into trouble here where people are claiming that subtypes of essential thrombocytosis are related to polycythemia vera. So you can't have a degree of erythrocytosis. Either you have it or you don't. And here they're trying to say the same thing, but they're using bone marrows to replace red cell measurements, which is, of course, a bogus concept. The confounding of the clinical phenotype of these so-called essential thrombocythemia patients is simple here. The JAK2 negatives have normal hemoglobins. The JAK2 positives actually have a high hemoglobin, and those are the ones who get the clots. So coming back to this is still a persistent comment as to whether these diseases are separate or related. And where does it come from? Well, it comes from phenotypic mimicry. One of these snakes is a lethal coral snake, and the other is a benign snake. I can't seem to tell the difference between them. And if we look at the World Health Organization criteria for PV and ET at 2016, you see a number of things here. One, there is a gross mistake here. There is no safe hemoglobin or hematocrit level. This is a recent study just to prove that once more if it needed to be proven again. And second, the presence of the JAK2 V617F mutation is not enough to tell you which disease you have. Now, this has been perpetuated in this study here, which claims that JAK2 mutated essential thrombocytosis and PVERA represent different phenotypes of the same neoplasm. And of course, these authors have made the same mistake. They've ignored even the inadequate WHO diagnostic criteria, because here you see in these ET patients, some of them have high hemoglobin levels, and here's another one where you get grievous confounding of ET with PV and even PMF. And if we look at the actual data in this one study, and I think I'll focus down here, here are the allele burdens, and somehow there's an overlap in the so-called ET patients with the PV patients. It's interesting to have the same low erythropoietin levels, and the ET patients tend to overlap in hemoglobins with the PV patients. So what's going on here? Well, here's a study from our lab years ago showing disease duration, the allele burden, and just look between ET and PV, and you see a lot of absence here. ET patients don't get homozygosity, whereas PV patients eventually all do. And if we look at someone else's data, Rosemary Gale, you can see with clonality, the clonal population in ET stays constant because the patients are all heterozygote, and the degree of change from the JAK2 mutation, except for this one patient, is negligible. And if you look at the stem cells in these three diseases, you can see that ET is distinctly different than PV. And more importantly, if you look at gene expression, this is gene deregulation in PV in women, half as many genes deregulated as men, but they share the core genes responsible for PV. And here's the same thing done with data from a study from Dr. Panucci's lab, and you can see ET more dysregulation in the women than the men, but only 17 genes, only one of which has anything in common with PV. So they're genetically different, their natural histories are different. And I think it's time to start to correct the record on this. Now, PV is not a monolithic disease. Here's a patient whose hematocrit rose over many years until she came to see us and we brought it down to normal. I would say this started out probably 1962. I lost contact with this patient in 1994, but she was only requiring phlebotomies up to then. Here is the aggressive PV, and who are these patients? Well, this is a very nice study from Italy, which shows that this is a small group of patients, and it also shows that if you have fibrosis and no risk factors, in other words, no anemia for sure, the myelofibrosis does not affect blood production. It's a bad stem cell that does. So we have the small group of patients, and I will define them later in another lecture in this workshop. But what about the conflation of PV and ET with pre-fibrotic myelofibrosis? This is a disease that only exists in the minds of those who choose to believe in it. And you can see here, so-called WHOET, this can't be because here you have hemoglobin levels of 17.6 grams. And here's early PMF, which again has exceeded the PV criteria of the WHO. And here is a study, another group of patients, 4 patients here. Here's one who has 4 out of 4, standard of the criteria for myelofibrosis of the marrow, but is not anemic and has no splenomegaly and is a CALR type 2. She's called low risk ET, but is considered to have prefibrotic myelofibrosis. And here's another with 2 out of 4 grades of reticulum, not anemic, and has CALR 1. Again, a female, and this would be considered ET by clinical grounds. Here's a patient that has grade 1 myelofibrosis, no anemia, and a big spleen, who is considered myelofibrosis low risk with JAK2 V617F. I would suggest this patient probably has polycythemia vera with a big spleen and a normal hemoglobin level. And finally, here's a patient with no fibrosis who has clearly polycythemia vera and is not anemic. And this is not prefibrotic myelofibrosis, this is polycythemia vera. And here's a patient of mine that was sent to me in 1993. She was thought of in 1985 to have either PMF or ET. When she came to see me, she was not anemic. She had increased blood counts, but she had massive splenomegaly. She couldn't have primary myelofibrosis, and indeed, she had PV. So let's end up with looking at ET. And here's the ET treatment algorithm from 2013. no fibrosis, arterial thrombosis, venous thrombosis. Well, let's go. That was contemporary then. Here we are 6 years later, and what has happened? We now go to very low risk disease, low risk, intermediate risk, and high risk. And I would submit, and these patients are all getting cytoreductive therapy that they clearly do not need. If we look at the IPSET score that was derived to create these various classifications, you will find again it is contaminated by patients not only who have hemoglobin levels that qualify for polycythemia vera according to the World Health Organization, they've all been treated with various cytoreductive agents. So I don't find these scores either useful or appropriate, since they have not, they are retrospective and they are contaminated by several confounders. So let me end up by saying that ET, PV, and PMF are genetically and clinically distinct disorders with different natural histories and therapies. Here is a study of stem cells and in ET, PV, and primary myelofibrosis according to time and splenomegaly. These diseases, ET has very low stem cell burden indicated by these asterisks. PV has a higher stem cell burden and more homozygotic cells, but this occurs over time. And primary myelofibrosis, there is no correlation with time, but there is a correlation with large spleens and homozygosity. So in summary, the MPN are a unique group of myeloid neoplasms because their gain-of-function driver mutations cause production of normal blood cells. These acquisition of these mutations is subject to host genetic variation. Because the mutations are present in the hematopoietic stem cell, you can get multiple restricted myeloid repopulating cells and clonal succession between these three diseases over time. Because the driver mutations activate JAK2 V617F, phenotypic mimicry is the rule, both clinically and in the bone marrow. But PV is the ultimate phenotypic expression of JAK2 V617F. It's a diagnosis of exclusion. The WHO diagnostic criteria don't reflect the clinical behavior of the NPM hematopoietic stem cells, and failure to even follow these inadequate diagnostic guidelines has further compounded clinical diagnostic error. Failure to appreciate the quantitative assessment of the JAK2 allele burden, that it's useful both diagnostically and prognostically, is a serious and unfortunately common error. PV and ET are distinct genetically and clinically. Prefibrotic myelofibrosis is not a distinct genetic or clinical entity, and because of host variation, genetic variation, each NPN patient represents a unique clinical problem, which speaks to the importance of precision medicine and coming to agreement on an appropriate diagnostic criteria for these disorders. I thank you.
Thank you, Jerry. And now I will discuss the topic of MPNs as a genetic spectrum. So I'm going to discuss MPNs as a disease spectrum. And the key question here are genomics the key to one's destiny? These are my disclosures. So let's talk first about genotypes and phenotypes. The hallmark of MPN pathophysiology is aberrant activation of the JAK-STAT pathway. And as of course we all know, mutations in JAK2, calreticulin, and MPL account for the vast majority of driver mutations that are observed in patients with MPN. Of course, there are about 10 to 15% of patients where the driver mutation or driver event has not been identified. Nonetheless, genomic profiling has demonstrated that such patients still display hallmarks of JAK-STAT activation in terms of gene expression. But given the fact that this is part and parcel of all of the MPNs we discuss, how do we explain the variability in phenotype? Of course, there is variability in the phenotype with regards to blood counts, with elevated hematocrits in patients with polycythemia, cytopenias in patients with myelofibrosis, and of course, pathologic variability in terms of bone marrow cellularity, megakaryocyte morphology and clustering, and of course, reticulin fibrosis. As well, it's important to remember that MPNs don't necessarily fall into these four buckets, and there are overlap syndromes. So clearly there are phenotypic variabilities, and that of course extends into variabilities in outcomes. If we look at mortality as an example, at 15 years, the cumulative incidence of mortality is certainly higher in patients with overt myelofibrosis and prefibrotic myelofibrosis, and lower in ET and PV patients, whereas thrombosis seems to be the more prevalent issue with patients with polycythemia vera and essential thrombocythemia as compared to patients with MF or prefibrotic MF. Do the genetics help to explain this spectrum? Well, in part, we know that there are variations with regard to the driver mutations in terms of homozygosity. And so we see that in patients with polycythemia and myelofibrosis, there is a higher prevalence of homozygosity of the JAK2 mutation as opposed to patients with ET. And similar observations are known with MIPL in patients with myelofibrosis. Perhaps that explains some degree of the spectrum of the phenotypes that we observe in these patients. But what about other mutations? Certainly, beyond the JAK-STAT driver mutations, there are a number of other mutations that have been identified in patients with MPNs. Among the most common of the non-JAK-STAT drivers are TET2, ASXL1, and DNMT3A. But importantly, there is a spectrum of mutations, many of which occur at very low frequencies, of course. But there is quite a range of different mutations. Some of these can be organized, of course, by their impact on specific pathways. But perhaps this starts to explain some of the variability that we observe in these patients. What's the evidence for that, though? Well, some of the evidence comes from gene expression profiling, where if one looks at the gene expression profile of MPN patients with and without TET2 mutations, it's quite clear that patients with TET2 mutations cluster independently of those with non-TET2 mutations. And so at least on a gene expression level, that provides one argument that other mutations change the spectrum of the disease. But what about biologically? Well, a lot of our data in this regard comes from murine models, as it is relatively easy to combine two alleles and examine a phenotype. A great example of this is the combination of JAK2 and TET2 mutations in work by Anne Mullally's group, where the combination of JAK2 and TET2 alterations demonstrates phenotypic differences. And here there are increased white counts in mice with both mutations, but quite significantly there was a marked increase in spleen size of animals that had both mutations, and there was in fact a competitive advantage for the stem cells arising from dual JAK2 TET2 mutations. Similar observations were made by Steve Lane's group in regard to the loss of DNMT3A, which again is one of the more frequent alterations that are observed in patients with MPN. And in this particular case, if one looks specifically at the bone marrow fibrosis in the B panel, mice that had both JAK2 and loss of DNMT3A had markedly increased fibrosis as compared to either JAK2 mutant mice or mice with just loss of DNMT3A. And there was a marked increase in the size of the spleen in mice with JAK2 mutations and loss of DNMT3A as compared to JAK2 mutations alone. So biologically, this provides some evidence that the addition of other mutations aside from JAK2 or a JAK-STAT driver mutation plays a role in changing the phenotype of the disease and helps to make the argument that the spectrum of phenotypes that we observe might be explained by genomic alterations. Clinically, this is a more difficult thing to define because, of course, many of these mutations are low frequency and they don't always occur as a single event. Often patients can have more than one mutation. So it becomes somewhat difficult to try to define the impact of a specific mutation on a patient's phenotype. One example, though, of this is the presence of U2AF1 mutations in patients with myelofibrosis, where this particular mutation and a particular variant, in fact, has been associated with both anemia and thrombocytopenia. And this is a good example of a genotype resulting or being associated with, rather, a specific phenotype in MPN. It's important to note, of course, that has prognostic significance. As we know, patients with anemia and thrombocytopenia tend to have a worsened prognosis. Now, beyond the simple addition of mutations, the other argument is that the order of the mutations does actually make a difference. And, of course, one of the key questions has been, how do we explain patients having a JAK2 mutation and some of those patients having a polycythemia phenotype or others having an essential thrombocythemia phenotype? Part of the explanation appears to depend on what mutations occur in what order. And in this particular example, the presence of a TET2 mutation first was more common in patients with ET versus those who had a JAK2 mutation first, in which polycythemia was the more common phenotype. Again, making the argument that it's not only the specific mutations that co-occur, but also the order in which they occur. Now, beyond genotypes and phenotypes, what do we know about prognostication? Do the outcomes of patients differ based on their genotype with regards to their risk of thrombosis, to the risk of disease progression, and to their potential response to treatment and ultimately survival? What do we know about this? Well, since the discovery of the calreticulin mutation, it has been apparent that, at least in essential thrombocythemia, there are differences in the risk of thrombosis depending on a patient's JAK-STAT driver mutation. And in particular here, we see that patients with calreticulin mutations seem to have a lower prevalence of thrombotic events as compared to JAK2 mutant patients. And the same, to some degree, is also seen in MPL mutant patients. So JAK2 emerges as a risk factor for thrombosis, and that begins to allow us to stratify a patient's prognosis based on their genotype, which is a powerful thing. So we can take a group of patients who we call ET patients, and yet we can use these data to stratify them in terms of what we really think their risk of having a thrombotic event. And by extension, we can therefore modify their therapy accordingly. I think this is an important example of the spectrum of MPNs being defined by their genomics and ultimately having an impact on how we treat the patient. So, as an example, traditionally, we had risk stratified patients with ET into low risk, those being under 60 or having never had a thrombotic event, or those who are high risk, and that would be patients, of course, over the age of 60 or with a history of a thrombotic event. And our traditional management approach had been to give cytoreductive therapy to patients with ET who are high risk. But now, with the advent of these genomic findings, we've begun to modify and further stratify patients' risk. And so now we have categories such as very low risk, where it may be reasonable not to even give aspirin, as well as intermediate risk, which really pertains to the non-JAK2 mutant patients who are over the age of 60 but have never had a thrombotic event. And these patients who historically may have been given cytoreductive therapy really no longer require cytoreductive therapy. What about prognosis in ET and PV beyond just simply the presence of the risk for thrombotic events? Well, we certainly know that some mutations do appear to also play a role in the risk of PV patients progressing, as an example. So this is the so-called MIPS-PV, which is a risk stratification score that incorporates both clinical variables as well as genomic variables. And in this particular instance, the presence of the SRSF2 mutation appears to increase the risk of disease progression in this data set. In a similar fashion, it also appears that splicing factor mutations and p53 mutations play a role in the risk of disease progression for patients with essential thrombocythemia. So, of course, the presence of any of these mutations certainly has an adverse effect on overall survival in patients with ET, leukemia-free survival, and the odds of myelofibrotic transformation. And again, historically, we had data that said to us that the lifespan of patients with ET is largely the same as the general population. But now we begin to risk stratify, and we begin to understand that, yes, a group of patients can have the diagnosis of ET, but their outcomes may be markedly different depending on their genomic profile. This has perhaps been best characterized and studied to date in myelofibrosis, of course, where, as with ET, the driver mutation appears to have a prognostic impact. Calreticulin mutant patients certainly appear to have a better survival than those with JAK2 or MPL mutations. But in particular, those patients who we call triple negative, who have none of the known driver mutations, really appear to have the worst overall outcome. Again, patients with the same disease, overt phenotype, ultimately seem to have different outcomes, defined by their genetics. Beyond the driver mutations, we've known for some time, of course, that the presence of other alleles such as SRSF2, EZH2, ASXL1, and IDH1 and 2 appear to increase the patient's risk of disease progression to leukemia. And this list, I think, is growing. More recently, NRAS and KRAS mutations have also been demonstrated to impact negatively patients' overall survival, as well as the risk of leukemic transformation. And in fact, this has now been incorporated into a number of different scoring systems, but here I'm showing you an example, the MIPS-70, which is a mutation-enhanced scoring system, taking into account important clinical variables that have held up across different scoring systems, as well as the genomic profile. And in this particular case, the absence of a type 1 CalR mutation, or the presence of high molecular risk mutations, which we've just discussed, ASX, EZH2, SRSF2, and IDH1 and 2, are all weighted to give us a patient's prognostic impact. And this is potentially practice changing, as patients who may have had a low risk profile now have an intermediate risk or high risk profile when the genomics are incorporated. Certainly that could change the management of such a patient with potentially a referral to stem cell transplant or enrollment in a clinical trial, whereas without the genomic information, we may have treated all patients simply based on their clinical variables. What do we know, though, about the impact of mutations on treatment? If we are to argue that the genomic profile has an impact on the spectrum of the disease, then it follows that management may be altered. As I've argued with the MIP-70, certainly that could change one's practice in terms of sending a patient to transplant, but do we know anything about what mutations do in terms of patients' odds of responding to therapy? Well, the presence of 3 or more mutations, or the presence of ASXL1, EZH2, or DNMT3A mutations certainly seem to have a detrimental effect on patients' response to ruxolitinib. And in particular, the time to treatment failure seems to be much earlier in patients with these genomic characteristics. So this begins to tell us a little bit more about what expectations we might have with regards to a patient's treatment. And certainly the response to ruxolitinib is variable, but now the genomics may begin to explain some of that variability. In a similar fashion, the impact and outcomes of patients who undergo a stem cell transplant also do appear to be influenced by genomic data. And in this particular instance, patients with calreticulin mutations in this series appeared to have a better outcome, as did patients without an ASXL1 mutation. There are now several papers in the literature, all with slightly different results, but all arguing that the genomics in fact do have a role in predicting a patient's outcome when receiving an allogeneic stem cell transplant. So if we are to argue that the MPNs are a spectrum of diseases, then we should reasonably expect that one can take a genomic profile regardless of the patient's underlying phenotype, and categorize them in terms of their risk. And this was the outcome of the landmark paper by Grinfield et al. In the New England Journal, in which patient outcomes were stratified essentially into 7 different groups based on the genotype. The highest risk patients are those, of course, with p53 mutations or p53 disruptions, and even in both PV and ET, as well as in patients with myelofibrosis, that particular genotype is associated with a worsened survival and a higher risk of leukemic transformation. Whereas on the lower end of things, patients with the JAK2 mutations, that is heterozygous and who have not had an NFE2 mutation, appear to have a relatively benign course in terms of survival and risk of leukemic transformation. So this piece of data is fundamentally, of course, arguing that regardless of the regardless of the phenotype, the genotype may predict the patient's outcome. And I think that this fundamentally argues that the MPNs are a spectrum and they can be genomically identified. So to conclude, the phenotype of MPNs may be linked to the mutational profile and to the order of mutation acquisition. The impact of individual mutations remains to be determined, but appears to impact disease phenotypes in preclinical models at least. Certainly the risk of thrombosis is in part influenced by the JAK-STAT driver mutation. The risk of disease progression, of course, across MPNs strongly correlates with the presence of certain non-JAK-STAT pathway mutations. So, although the clinical parameters are certainly important in the management of the disease and they certainly contribute to the thrombosis risk and disease progression risk, it's absolutely clear that the mutation profile plays a major role in disease outcomes. And this includes things such as response to therapy, as well as the risk of progression. As the impact of individual mutations on MPN phenotype, prognosis, and the response to therapy becomes elucidated, MPNs may be best understood as a spectrum of pathologies driven by a specific genomic profile on the individual level and managed as such. Thank you so much for your attention. Well, thanks for joining us for the panel discussion. I think we've had, I really enjoyed Jerry's talk, and I think we have a lot to talk about. But I think I would open, Jerry, by saying we can agree on a couple of things to start with. One is that the JAK-STAT pathway is the hallmark of disease, and that the guidelines as they are currently are inadequate. But perhaps we have different thoughts on to why they're inadequate. I think certainly you've made the argument that many of the studies have perhaps confounded PV and ET, and perhaps that is certainly attributable to the change we've had in guidelines, and certainly they not being perfect tools by any sense. But is it reasonable to say or to think that the boxes that we draw around these diseases have fuzzy borders, or do you really think that they are really distinct boxes?
Well, I think there's 2 parts to that answer. I'm going to give the second part first, and that is going back to your presentation, which I really enjoyed, is bringing in allele burdens and the presence of other mutations, which at the end of the day sort of supersedes everything else in terms of prognosis and in terms of treatment. But at the same time, for most of these patients, these are gain of function mutations. They're making too many normal cells. And there's one thing we know about that is it's very hard to suppress a normal bone marrow with chemotherapy. And in fact, the whole basis of the success of chemotherapy, say in acute leukemia, is you're not going to kill all the normal stem cells. And the problem is you can't quite kill all the abnormal stem cells. So treating these diseases, which are gain of function with chemotherapy in the absence of symptoms, except for the hematocrit, makes no sense. And what you're seeing here, Raajit, I think, is sort of the evolution of the history of the treatment of these diseases going back to the early days when people didn't understand how to phlebotomize. And phlebotomy got a very bad name, and it still has a bad name in certain circles. And yet, it's the simplest, cheapest, and most effective way to stop thromboses. Chemotherapy is not an anticoagulant, and people tend to forget that, but it's embedded in the literature. This is a problem. And I think before you can get to be precision medicine, which is where you are with the genomics, you have to have the right diagnosis to start with. And you see that the literature, World Health Organization guidelines, okay, let's have reality here. It's hard to get a red cell mass, and it's even hard for us now for technical reasons we don't have to waste time with. But you can do without it if you follow simple guidelines and say, am I missing PV? And if someone comes in with a normal hematocrit and a Budd-Chiari syndrome, which is what happens in women, that's PV. That's not ET. And in the next session, I've got some slides on that. So you don't go after them with chemotherapy to start with, because that's wasting your time. The polycythemia vera study group proved that. In fact, if you want to go back, that is the only randomized controlled clinical trial with therapeutically naive patients. So that gives you your acute leukemia statistic of 1.4% in a naive patient, and it gives you your leukemia with chemotherapy. But of course, people did not want to believe that. So we've gotten into this horrible situation with partially treated patients, confounding patients, and then trying to, the clinicians, they must, who are in private practice, must want to cry because these classifications change and have no meaning. But let me stop because I've already said that message.
Fair enough, right? Well, I guess let's talking about classifications, right? In the genomic era, the question, I think, one of the questions, of course, is there an opportunity to redefine how we not only prognosticate, but how we classify patients? Of course, we know that certainly the patients don't necessarily read the textbook, right? And we see patients who have features of both, and they get this MPN unclassified diagnosis. And then, of course, there are I think more pointed examples, such as JAK2 positive patients who are given a diagnosis of CMML in one center, and in another center that bone marrow is read as myelofibrosis with monocytosis. Which, how do we make that distinction? So do you think that in the modern era, if taking into account a lot of the factors you've mentioned, so things like sex, the allele burden, and then as well as the other mutations, do you think we have an opportunity to sort of redefine the diagnostic criteria? Because as you're pointing out, that's the first step before we start talking about treatment.
Well, yes, we do have that possibility, but I think you first have to start off with the basics, that men and women are different and they have to be treated differently. And this is true with respect to phlebotomy requirements. And for some reason, I'm sure you learned the same thing I learned in medical school. Women don't make much in the way of androgens, and they have lower red cell volumes than men do. And so to say in P. vera, which is such an easily treatable disease, that you only phlebotomized to below a hematocrit of 45, you're going to have a lot of symptomatic women, you're going to have thromboses, and everyone's going to wonder what's going on. So I think we can't lose sight of basic physiology here. And we have to ignore what, I hate to put it this way, some experts say, because they're flat out ignoring physiology, which is the most important aspect of disease that we have to take into consideration. So there's that. I think the next thing is, when do you, and this was brought out in the first session this morning, and you discussed this as well, when does another mutation have significance? And I think the fact of the matter is that in younger people, I don't even bother. It's in the older patients that you want to know about prognosis. And at the moment, it's a very sticky wicket, if I can use that analogy, because you can have a subclone that isn't that important. but you can have a subclone that's absolutely vital, and that's the TP53. And your studies have brought this out, and Ron discussed this morning at length. That's, I think, the, how can I say it, that's the evil doer. And if you look at patients who have JAK2 V617F and they get leukemia, and their leukemia is positive for the mutation, they do worse than the patients who go from JAK2 V617F to JAK2 negative, because JAK2 drives right through, it allows the P53 cells to keep multiplying. And they have then a multiplication advantage, and then it's just putting gasoline on the fire. And if you add hydroxyurea to that, and everyone, I heard some skepticism in earlier talks, I mean, that is a gatekeeper. That transactivates TP53. It causes the 17p deletion. So you can make things worse rather than better. But I think we have to keep our eye on TP53 is a really important one. And getting back to the monocytosis, I adhere, you get monocytosis with these diseases, but you don't get the type of monocytosis that characterizes CMMOL. So in that group there, I would be very aggressive. So I think you can pick your spots here.
So I think a lot of interesting points, right? And I think your point about the what do those mutations mean? And when we see co-occurring mutations, are they passengers? Are they going to contribute to the pathophysiology? I mean, certainly, it's one thing to model this, of course, in mice where in a genetic model the VAP is essentially 100%, but that's not the reality of humans. And I think that there's the issue of what is a specific mutation. If we take ASXL1 as an example, there are a number of variants, some of which it's just not clear that they are pathological. So just because somebody has one, does that mean anything? I don't think we know the answer to that in all cases. And of course, there's the clonality issue, which I think with our current technologies that we use in the clinic are probably not sufficient to address this question. The technologies in the laboratory right now, the single cell and whatnot, are more helpful to answer those types of questions. But I think, as you're saying, and I think as we agree, this is certainly not a black and white issue. It's not presence or absence. P53 might be different, and particularly in the context of 17p loss. But certainly, there's, I think, a lot more nuance than we're currently prescribing in the genetics.
Yeah, no, I totally agree. And I think you really have to pick your spots here when you're doing what you're doing. So if somebody, and I also, PMF is it's entirely different disease than the other two. They may evolve in that type of direction phenotypically, but good old PMF starts out like CML, high allele burden, and you're off to the races. And then I think the bone marrow tells you what's going on. I don't mean the histology. I mean, if you're anemic, it's not a good thing. And that this would be true in each of the other ET and PV. Having myelofibrosis, that's meaningless. That's a reversible reactive condition. It's the stem cell that's key. And I think looking at stem cell burdens, I had a slide there of in the 3 diseases, and you can, if you go, the stem cell burden that no one's really looked at, that's very easy to look at, is the aldehyde high expression CD34 positive cells. You can do that in flow cytometry. That should almost be a clinical test. And when that burden goes up, then you have a problem. And if you have ASXL1, if you have the right mutation, I think you can start to put things together. But unfortunately, the field refuses to go in that type of direction and is just tied up with A, the diagnostic problems, which patients don't deserve, and B, this fascination with chemotherapy, which is essentially futile, except if you want to make the blood counts normal, which has no survival benefit whatsoever.
No, important points. So I think unfortunately our time is running short, but I've absolutely enjoyed this discussion, Jerry, and it's always a pleasure to learn from you. I think that it's interesting that a lot of the sort of data with regards to phlebotomy and a lot of the historic data with polycythemia now with the new genetics, I think there is potentially a possibility to put those things together and hopefully forge a new diagnostic criteria.
Agreed. I've enjoyed this, Raajit. It's sorry we can't get together on a more personal basis, but as they say, it is what it is.
It is what it is. But yes, no, I very much enjoyed the conversation. Thank you to the audience. And I'm now going to turn things over to Dr. Bose.